Hi, I hope you're enjoying HCS510 so far. I'm just popping up today, I guess, with a video just to have a little bit of a chat with you about some practice examples that I've experienced in my own professional career working in mental health, and how some of the experience of working with involuntary clients and the mental health legislation has impacted on some of the ways that I've looked at, I guess that being congruent with my social work practice, and trying to be able to consider how being able to be recovery oriented and being able to be respectful and empowering within my practice is something that can still happen, even though that there are obviously some challenges that come up when you're working with people within an involuntary kind of a framework. So I think that the reason that I wanted to do this really is quite often students have reflected that they find it more relevant when they can see a clear application of how something might look in practice. And so reading it and kind of looking at it in a two-dimensional way doesn't always give a sense of what that might actually look like in the real world and when we're talking about real people. So I think one of my very early experiences that I often think back to when I look at working with involuntary clients comes from my days of working as a community mental health social worker. And I do recall very clearly a day when I had a client referred to me who was on a community treatment order, and she was what was described to me in the handover process as somebody in the revolving door and a frequent flyer, and these kind of terms came about. And so there was a very, very fat, multiple volumed file that was handed over, and a sense that for this particular client there were a number of risks, and she was described using words like insightless and kind of non-cooperative, and there were sort of a lot of things like this that really, even in that very early handover process, actually had really quite negative connotations for what the experience would be like to work with this woman. So it was a really interesting process when I went out and met her, and she was a single mum with 3 kids, and so there were some challenges around how her mental health condition was enabling her to parent, and some issues with the kids in terms of attending school, and some budgetary problems around the kids being fed appropriately and all of this kind of stuff. So we started out, and she kind of accepted me as part of her community treatment order package, I guess, initially. And so there was an agreement that I would visit her each week, and part of that was that she also received an injection of her medication, an antipsychotic medication. So she had a diagnosis of schizophrenia. I think one of the things that was really interesting for me was, I was fairly new in the field at that point in time, and I remember having, all of this knowledge, all of this psychoeducation, and this was what we were aiming to try and do, was to help inform the people that we were working with, the consumers of the service, about their illness and their treatment options. And so I recall going out there and sitting down and saying, I have this great information about schizophrenia and about symptoms, and let's have a look at, thinking about the time that we're going to spend together. What might we do? Are there other things that we can do in this time? And it was really interesting that what she actually did was she gave me a book, and she said, "That's okay," she said, "but I don't believe that I have schizophrenia." And so, of course, I've already been, pre-warned that this person is insightless, for the want of a better word that had been described. And it was a really interesting thing that she handed me a book about spirituality and about psychic connections. And so she said, "I'll read your information that you've brought out, but I'd like you to read a couple of chapters of this book, and I want you to understand where I'm coming from and why I don't think I have schizophrenia. And this is my understanding." So I did. I took the book away and I read a couple of chapters of this book that she'd given me, and thought it was actually really interesting to see her own understanding and her own explanations, I guess, within this book, and within this understanding of her psychic abilities and her spiritual connections. It was really clear that we were often talking about the very same things. We were talking about similar experiences that she was having, both positive and negative. It's just that we were using language that was very much, within the medical framework, and within the labelling of symptoms, and looking at ways that we could actually get rid of those symptoms, because it was very much about relapse prevention and control of that kind of, symptomatic nature of her illness. And so the reason I'm telling you this, I guess, is because for me, it was something that for the first time, I think, in this person's long history of being involved with the mental health service, that somebody had actually taken her seriously enough to listen to her own understanding and her own personal experience of what she was going through, that lived experience. And so instead of then being able to say, well, these are your symptoms of your schizophrenia and this is what we need to do to get rid of them, we actually opened up a dialogue where we were talking about, you know, what that meant for her. And for a lot of the part, she actually didn't want to get rid of the symptoms. She enjoyed the communication that she was having with the voices, essentially, the hallucinatory, people that she was communicating with. And so for her, that wasn't a negative experience. That wasn't something that she wanted to get rid of. And so being forced to take medication that was essentially designed to take away something that she enjoyed was a really disempowering process for her. It, of course, posed challenges for me as a mental health clinician and as a social worker in that, well, what do I do with this? I can't very well recommend that she be taken off her medication because she prefers to have symptoms of schizophrenia. It seemed like a really difficult kind of dilemma that I was in. And so what actually happened was, over a really long period of time, we caught up every week for months and months. And we talked a little bit about, her experiences and how she found, the experience of the hallucinations and some of the impacts that was having on her life and also on her kids, starting to open up a sense that the impact of her symptoms wasn't just about the impact on her, it was about what it was also doing to her family. And throughout that dialogue, and as we began to forge a really good working relationship, she was able to recognise and disclose to me that actually sometimes those voices weren't always positive. Sometimes they were in fact quite negative and quite derogatory. And so that kind of was really a starting point, a turning point, where she began to acknowledge and accept that there were times when she was taking her medication that in fact, that negative symptoms went away. And although some of the positive symptoms were still there, she was able to better control and to reduce the number of negative symptoms and the negative voices that were happening for her. And so it was a really interesting journey that we went through in trying to kind of empower her to find words and descriptions around what she was going through. And ultimately, it was a good news outcome. For this person, we actually went to the Mental Health Review Board after it was 12 months, and the psychiatrist read the file and had sort of said, long history, she'll be back if we take her off her community treatment order, she'll become non-compliant, she'll stop taking the medication. And so one of the things that we had discussed in the times that we'd been catching up was the idea of the medication as potentially being beneficial. But the biggest problem she had with it was that it was actually in an injection. It was a very painful injection that was given to her in the back of her hip. She was quite a thin woman, and so that it was something that was a painful, and it was she found it a very demeaning kind of experience to have to turn up and have these regular injections at the clinic. And so we talked about the idea of trialling an oral medication, and the psychiatrist was very much against it. I advocated that it would be worth a try, and that she was indicating that she was happy to try and take it. And so eventually she came off her community treatment order, and it was a really lovely experience that she continued to still come and catch up with me, and we continued to work on other strategies, and we did some family-based work and improved some of the outcomes for her children and her family, and looked at different ways that her mental health had contributed to other problems outside of just the symptoms and the relapse prevention. And she did that as a voluntary client. She continued to come back and continued to see me for quite some time, and until she was she felt ready to go on and to do that on her own. And so it was a really I think it was, had I just perhaps taken that file and taken the language and taken on board the kind of the sense of an insightless and non-cooperative and frequent flyer kind of language that had come with that particular person, I think there was a real risk that I would have just done what had to be done and turned up and checked off boxes and continued to see that she was somebody who didn't use the language that we felt was appropriate. And so I think that kind of the opportunity to be open-minded and to be respectful that other people's interpretations of their experience is just as important as our own professional and kind of diagnostic stuff that we often bring in a mental health service system. So I think there was, for me, the take-home message from that was really just about being open to hearing both sides and to really being open to hear the lived experience. And you know, it was a good outcome. It was something that we were able to move on. And I've actually, you know, I've bumped into this lady. I live and work in a small rural area, so I do see people from time to time. And you know, I've seen her, and I've also seen some of her kids around the place, and they've often still popped over and said hi, and you know, been really grateful that there was a great turning point where she now feels empowered to manage her own illness and her own symptoms, and to do that, you know, in an empowered kind of autonomous way. And that's been a really meaningful experience and a really empowering one for that family and for that individual. And I think that this is, it's something that also pops up from time to time, I think, in terms of other legislation as well. And so I know that there's been quite a number of you who've expressed interest in looking at legislation around things like child protection or the drug and alcohol system. And I think it's also, a lot of these principles, they really apply when we're looking at involuntary treatment across other practice fields as well. Look, I certainly know that I remember working clearly with a couple where they both had a diagnosis of schizophrenia when I was in community mental health, and they fell pregnant, and so the mother was having some significant challenges because of needing to go off some of her medications, and so she became quite unwell during the pregnancy, and the stress and the anxiety that provoked you know, triggered some symptoms of relapse in her partner. And so it's a really unstable and a really complex kind of situation. When the baby was born, child protection were involved. The mother had a previous child already removed from her care, and so there were a lot of concerns about how this couple were going to cope with a newborn baby and what that would mean and what that would look like for them. And so, you know, I worked quite closely with child protection in those early few weeks, and there came a really difficult point for me where during a consultation, the father, who was my client, disclosed that he'd been having thoughts about hurting the baby, and so he's feeling very frustrated, and the baby wasn't sleeping very well, and so they, you know, subsequently weren't sleeping very well, and so it became a really difficult situation where he was feeling frustrated and expressed, you know, in the course of that he felt like putting a pillow on the baby's head as a means of being able to create quiet and to be able to relieve some of the build-up of stress that was happening around the baby crying, you know, quite often throughout the night. And so, of course, this you know, it prompted a whole raft of concerns for me, and I spoke to Child Protection Services about it, and I said, you know, I think we need to do something. But there was an option there for me, I guess, in that I could have just gone ahead and made that referral and made that report to Child Protection and not actually told the father. I could have done that when my details would never have been disclosed. That was part of the professional, you know, options that we had as referring parties. But it sort of didn't feel right. It didn't feel like that was actually going to be the best way to continue having a therapeutic relationship of any sort with this couple and with this family. And so, you know, I spoke with him, and he was furious and angry, and it was, you know, a really, really difficult conversation to have. But for me, the value of being able to say, you know, really openly, I actually have some concerns, and I'm really worried about what this means for you, what this means for your baby, what this means for your partner, and really talked about the idea of a referral to Child Protection as not being about, you know, looking to get the baby removed from their care, which was their fear, you know, having had that happen once before already. And so we talked a lot about the idea of Child Protection Services being about providing additional support, being able to help them find some strategies, and as much as it was a really difficult conversation, and it had, you know, and it was, you know, it escalated. It was a really, you know, police were involved when the Child Protection Services came out. He was really angry and very hostile, and I was pregnant at the time with my twins, and so he was very verbally abusive toward me and making threats, you know, to my children's safety and things like that. So it was, you know, it was a really rough session. It was a difficult kind of decision to make, to disclose that I was the one who was going to make the referral and what that would mean. But I always still look back on that and think, you know, yes, it was a really difficult decision, and it was a difficult situation and a difficult couple of days. But as it panned out, you know, Child Protection were able to do some fantastic work with the family, and they went away as a family unit to a parenting school, like a parenting program, and spent a week looking at the child's needs and how they could manage, you know, parenting at home and helping reduce her crying and improve her sleeping and feeding and all of those kind of things. And when the family came home, you know, he was quite grateful that they'd been able to access the supports, and we were able to continue working together. And I think that had had perhaps been done in a bit more of a covert way, I might not have been able to repair that therapeutic relationship in the way that we did, so that it could still continue to have some really positive outcomes in being able to work with that particular family. So I think sometimes it's also, there's making of really difficult decisions about being that person who is clearly going to enact legislation, somebody you've worked really hard to build trust with and to try and build and establish a rapport and a good working relationship, to be able to be the person who then actually takes away and disempowers. There are lots of ways to think about how we do that in practice, and so I'm not always, I think there are some really inherent risks in making decisions like the one that I did, to actually actively tell a person about that decision. But I do think sometimes not being secretive and covert about it, there can be some real benefits that come, to the longer term therapeutic relationship when that pans out. The very last pardon me, case that I wanted to talk to you about was a lady who I worked with for quite a number of years, who had bipolar disorder. And my first meeting with her was at a time when she was acutely unwell. She was experiencing a manic episode, and she lived at home alone in the community. And I went with our acute crisis team with the view that I was going to take over case management working with this lady. And it was she was very, quite elevated in her mood, and found it really difficult to see that there was anything wrong, and so was very reluctant to receive treatment. She'd had a negative experience a year prior to me meeting her, where she had been quite unwell in the community and had been taken involuntarily to an inpatient unit and had a really negative experience in there. And so she was quite fearful, quite anxious about what it would mean to go back and to have an involuntary admission. And so I worked alongside the crisis team, for a number of weeks as we tried to manage her illness and her symptoms in the community and to keep her safe. But unfortunately, things deteriorated quite significantly, and her relapse was quite public. It impacted a lot on her neighbours and on her family, and so the decision was ultimately made that she was taken in again against her will, and so police were involved, and she was taken to the local inpatient facility. And so it was a really difficult situation, because it had been the one thing that she'd been most fearful of, and so for that to be the outcome, it had some really serious consequences for her in terms of, when her manic episode abated, she became quite depressed, which is not uncommon for people with bipolar disorder. But she became very low in her mood and very fearful of another episode. And so we worked together throughout the course of a number of months and worked through her depression and some of her symptoms, and started looking ahead, because she was a very creative woman, and she was a professional artist by trade. And so she actually found that when she was depressed and in those low moods, she was very non-productive, and she struggled to work, and she struggled to actually, to paint and to achieve her artwork. But when she began to become, more manic and more elevated, she was very productive and creative and able to really tap into her preferred side of herself. And so it was a really challenging balance to try and help her look towards a place where it wasn't about being either depressed or about being really elevated and manic. It was about being at her best, where she could be productive. And so we had, we worked together for a really long time, and a big pattern had begun to emerge, that it was around that sort of autumn time often that she would, her mood would head down, and she was depressed a lot through winter. And then seasonally, as spring came, was often a time that was a really high risk for her, of her mood elevating and of a manic episode happening. And so we planned forward with that in mind, and we looked at some of her symptoms in the past and some of her early warning signs, and we looked at ways that we were able to perhaps avoid there being an inpatient admission, and looking at other ways we could manage it. And throughout the course of that, one of the things that she said to me, she looked me straight in the face and she said, "I need you to promise me that you won't let them take me to hospital this year, if I become unwell." And it's just kind of, it's almost a clinician's worst nightmare. You never really want to make a promise of something like that, because it's a promise you may not be able to keep. And I remember kind of skirting around it in every conceivable way possible, and offering, that we could build on strategies, and we could do the best that we could, but that I could never give her that promise. And so it was a really difficult lead up to spring that year. Her mood began to emerge and she began to feel really good. And we, had sort of history had suggested that this was going to be a really vulnerable time, and there was a really strong risk that she would potentially become unwell and require hospitalisation as she had done in the past. And what actually happened that spring was an enormous amount of work at a personal level, but it was such a rewarding time. I took it upon myself to visit. We increased it with her agreement. We increased our visits, and so I used to pop around there most days in the morning, and we'd have a morning cup of coffee together, and we'd chat and we'd look at what the day, and I'd be there kind of doing mental state examinations in my head and keeping an eye on her mood and seeing what was happening. And she began to become quite elevated, and we put in place strategies, and we actually ended up, she was so fearful of coming into the service because of past, having been removed from there and taken away and things like this, that I actually managed to convince, we had a fabulous psychiatrist at the time, to come out with me to her home and to visit there. And one of the things we actually found was that she hated the medication because it made her feel dull and it impacted on her artistic and creative thinking processes. And so the psychiatrist actually gave her a little bit of autonomy to, increase her medication for that period, and said, I understand that you may not want to stay on the high doses all year round, but definitely in the lead up, let's look at increasing the dose. Let's look at curving, this away from a really peaky manic episode. And so being able to have a great psychiatrist who was open-minded enough to see that, this person was really struggling and really needed some, sense of control over her own experience and her own illness. And, we worked together in partnership, the three of us, with the psychiatrist and myself as her, community-based case manager, and the consumer herself, about how we could avoid this and how we could keep her at home. And it was quite work intensive in terms of very regular visits and lots of support to monitor her medication and to monitor her symptoms. But ultimately she was able to stay at home throughout the duration of her relapse on that occasion, and the outcomes were just incredibly positive. It really gave her a sense of control over her own situation and over her illness, the one thing that she'd been powerless against for so many years. And so it was a really positive experience in that she was able to then feel a little bit more in control. And we continued to work together over that following 12 months, and our visits were less frequent at times when she was less vulnerable. But because she'd actually been able to be managed in the community, her depressive episode wasn't quite as deep and as dark throughout the winter. And then the following year, when some early warning signs began to emerge, she was really prepared for that. And so she actually took the initiative to talk to her doctor and increase her medication, and was able to actually kind of really only have a tiny little bump in the road that following year. And so it's actually now, I still see her around as well from time to time, rural living, rural practice, and and she's doing so well. And she actually now, I've been almost 8 years gone from there now, and she hasn't had a relapse in 8 years. So that ability to be able to kind of take control over her own illness was a really fabulous outcome and a really empowering process. And although I guess I'm acutely aware that, some of these stories and these reflections that I'm sharing with you are good news stories. They're not always good news stories, but I think it's about kind of highlighting that it's very easy to get caught up in, the negativities of involuntary treatment and being able to think that it's something that's, it's a foregone conclusion, that it's difficult and it's disempowering and that it's taking away somebody's rights. But I think it's also important to know that as social workers, we're coming from a really solid base of evidence that supports the practice that we do, to be strengths oriented, to focus on ideas of early warning signs and being able to bring out the strengths and the resilience that people have, to empower people to have control over their own illness and their own life, and to really embrace those recovery oriented kind of models of practice, are some real advantages that we have as a profession, that had we only focused, and particularly in those examples that I've given you, had I only focused on the typical medical model or on those kind of psychiatric outcomes, it would have been a really different outcome. And I think that it's kind of important to highlight that it's definitely possible to work and to practice in a strong medical model and to still be able to use our social work skills and to be able to draw on, the strengths and the evidence base that we have that says this stuff works, and that recovery oriented practice is, is very much worthwhile for the consumers that we're working with. So anyway, sorry for my big waffle on. I just thought it might be useful, to think about it from the perspective of, putting some of this stuff into practice, and what does it actually mean to be a social worker in an involuntary treatment model. And, so hopefully some of, my own practice stories might have been able to just shed a little bit more light and give you something to think about. Okay, good luck. I hope you enjoy the rest of looking at involuntary treatment.